In vast majority of these patients, airway can be easily managed with supplemental oxygen and basic airway maneuvers, and you can defer the placement of definitive airway till the patient reaches the emergency department. Now, these are the steps. So you have pre-hospital rescue devices, you have pre-hospital orotracheal intubation, and you have pre-hospital failed orotracheal intubation. So you have to take care of each and every step here. So these are a few pre-hospital rescue devices which are the supraglottic airways. As you must have used the laryngeal mask airway sometimes during your training or sometimes during when you become consultants. You also must have seen the iGel supraglottic airway and a modification of the combi tube, which is the King's airway. So these are all supraglottic airways which become very good adjuncts for airway and trauma. A standard LMA insertion method is shown here. It consists of step 1, in which you hold it like a pen. Okay, then you do a tongue jaw lift maneuver here. That's the step 2. Then you push in the airway further till you get the resistance. That's step 3. And then once you get the resistance, you inflate the cuff. That's step 5, and make sure that you have adequate ventilation and the airway is in place. So more than that, this is a new adjunct, which is the supraglottic airway again, which is a modification of the laryngeal mask airway. And this iGel, as it is called, has a host of features that provide significant benefits to the patient and the clinician. If you see here, iGel has a gastric channel here. Okay, so that's your gastric channel here. You can see that here. That's a gastric channel here. Okay, and there's an integral bite block which is in the center here. Okay. You have a buccal cavity stabilizer which aids and eliminates the potential for rotation, which is here. You have an epiglottic rest here, which reduces the possibility of epiglottis folding down and the airway obstruction. And this is a non-inflatable cuff here, which is made from a unique soft gel-like material. And that's your distal end of the gastric channel. Now, you also can use this for fiber optic guidance and intubation if there's a difficult intubation despite putting this supraglottic device. Now you can see here, this is the connector of the iGel. It can be connected to any standard catheter mount or the connections. And this is the proximal end of the gastric channel. Now this gastric channel can also be used to put in a Ryle's tube or a nasogastric tube, decompress the stomach or to feed later on. Okay. And this is we have clearly displayed product information. For example, the size 4 here is for up to a 90 kg person here. So this is one of the innovative supraglottic airway, which is a modification of your laryngeal mask airway, and this really helps in securing airway in trauma. Now, this is the King's airway again, which is a modification of the combi tube here. Okay, I won't go into the details of the King's airway because this has been covered in few of the topics before. So this is how the King's airway looks like. So that's the distal cuff here, okay, which goes in the esophagus. That's the proximal cuff, which inflates at the base of the tongue and isolates the laryngopharynx from the oropharynx and the nasopharynx here. Okay, so King's airway is also a very good adjunct for securing the airway in trauma. Now, what about pre-hospital orotracheal intubation? Now, it should be reserved only for situations with clear indications for definitive airway management, and if there is experience and expertise which is available. Both are important, experience as well as expertise. If the orotracheal intubation has been shown numerous times to be associated with adverse outcomes in trauma, particularly in patients with traumatic brain injuries, and if it is required, it may be performed in one of the 3 ways: non-medicated intubation, sedation-assisted intubation, which is without paralytic agents, and of course, rapid sequence intubation, which we all know, which is sedation and paralysis-associated intubation. So what are the essentials before any of the airway maintenance strategies are taken place? It is essential to clear any blood clot and the mucus from the oral cavity and the nose. So to clear the airway, very obvious. And of course, to remove the foreign bodies such as broken dentures or Aval's teeth, which are not uncommon in trauma patients. Now, one should also control the tongue position in case of a symphyseal bilateral fracture of the mandible. Suppose you have a symphyseal bilateral fracture of the mandible, you should control the tongue position. And a word of caution when suctioning the oral cavity, always remember this: never suction further than you can actually see. Always suction on the way out, never suction for longer than 15 seconds, And as you all know, always oxygenate the patient before and after suctioning, because it involves some amount of hypoxemia, which may be fatal for some patients if they are grossly hypoxemic.